Good afternoon. My name is Milan. I'm a physiotherapist at Pain Free Health, and today we're going to discuss the Quadratus Lumborum. Quadratus Lumborum is a muscle that's located right along the spine. Here are the referred pain patterns. So the Quadratus Lumborum has superficial and deep trigger points. The superficial trigger points are sitting on the side, and they're going to be referring more into the front as well as into the side of the hip, whereas the deep fibers are going to be more referring into the SI joint as well as kind of down into the piriformis area. It's basically one of the most commonly overlooked muscular sources of low back pain, and it can cause satellite gluteus minimus trigger points. Gluteus minimus kind of sits right in here. It can give you that pseudo disc syndrome and failed back surgery syndrome. The reason why we have that is because of the fact that the patients who originally went in for surgery, they originally just had Quadratus Lumborum trigger points rather than no structural issues. It's basically the most frequent muscular cause of low back pain when recognized on exam, and it's found in about 32% of the cases of low back pain. So very important to always try and identify and see whether the QL is the source of back pain. Here's the fiber orientations. The QL fibers are oriented in three directions. You got the iliocostalis fibers, so meaning going from the ilium to the rib. You got the iliolumbar, meaning going from the ilium to the lumbar spine, and then you got the lumbocostal, meaning going from the lumbar spine to the rib. As you can see, it's got all different types of three different types of pattern. You can also it almost looks like three different muscles in one. So that's kind of how you have to look at that QL muscle. And the reason why this diagram here is very important is just to show how deep this QL muscle is. So you can see it's quite deep. It's under all these other muscles that are on top of it. So when it comes to dry needling and as well as palpation, you really have to press hard to be able to get to this muscle. So Quadratus Lumborum function. It's important in spinal stabilization. It controls breaks side bending to the opposite via lengthening contraction. It's essential for lumbar spine stability during movement, and we've shown in bilateral paralysis of the QL, walking is impossible even with a brace. Respiratory role, it stabilizes the last rib during inhalation and forced exhalation. And unilateral action, it fixes the pelvis as well as the spine. And it elevates the hikes the ipsilateral hip as well as lateral flexion of the spine towards the same side. It assists in lateral bending to the same side against resistance. So this is a very important function, but also it can have implications. Let's say the amount of work that this side is doing more than this side will, over time what's going to happen is this spine is going to start bending more towards that side because of the force that this QL has. Let's say the QL muscle has trigger points in it. Well, what that's going to do is that's going to shorten the muscle. The shortening of this muscle, what that does, that forces the spine to bend this way, giving the appearance of scoliosis. And that's called a functional scoliosis. Trigger point symptoms: severe low back pain, difficulty turning in bed, standing upright or walking, relief when a lumbar spine is unloaded, meaning when it's laying down with knees bent. It's aggravated by coughing, sneezing, standing, or unsupported sitting, and pain can mimic radicular lumbar pain. So all of this indicates is your typical low back patient that's had a very bad back spasm and seems to think that it's a disc issue, where in turn it's could be more of a QL issue. Functional limitations: restricted forward bending and side leaning. Disc issue, right? You would think. difficulty rolling in bed and climbing stairs, pain when raising from lying, and sitting without upper limb resistance. In severe cases, patient may even creep on hands and knees upon waking. So it's so severe that they can't even stand up. Pain referral patterns, growing testes scrotum, sciatic-like distribution, heaviness in hips, leg cramps, burning, and in chronic cases, the persistent deep ache at rest, sharp knife-like bursts with movement. Pain may be immobilizing and emotionally depressing, loss of vitality and endurance from constant pain suppression. Differential diagnosis of the QL trigger points. There's other muscles that can be involved. Longissimus thoracicus muscle and multifidi, so you can see these trigger points. Iliopsoas, this trigger point here. Lower rectus abdominis. You can see this lower rectus abdominis refers right into the back. So we want to also check those muscles out. Common misdiagnosis. A lot of doctors love saying this, trochanteric bursitis. Well, a lot of times that can come from the QL. Pseudo disc syndrome, sciatica. You always want to check the QL whenever someone comes in with sciatica. Key differentiation points: reproduction of sciatic pain with palpation of QL. So if you palpate the QL and gluteus minimus and you get those sciatic type trigger points, then you know that that could be the problem. You want to inactivate all those trigger points, and if you inactivate all of them, then that means, and the pain doesn't come back, that means it was the QL rather than the disc issue. Associated trigger points with the quadratus lumborum, meaning these are the guys you want to look at as well. Contralateral QL, ipsilateral iliopsoas, iliocostalis, external abdominal oblique, latissimus dorsi muscle, as well as the glute muscles. Very, very important to look at these muscles as well when you do have QL, when you identify QL trigger points. Activation of quadratus lumborum. Trigger points can be anything: bending, reaching, quick stooping, sudden awkward movements, raising from a deep-seated low position, leaning sideways, putting on pants while standing. This is a very common one. Major trauma, sustained repetitive strain. This is, a lot of patients do this: gardening, scrubbing floors, lifting cement blocks, walking, jogging on a slanted or uneven surfaces, secondary overload, limb length changes, walking cast. Someone gives a patient an orthotic, or they buy an orthotic that's not the same size. This can all induce quadratus lumborum trigger points. Patient examination. The reason why this is so important is because the QL as well, whether you have a patient sitting or laying down prone like this, sometimes what you might do is you might see that S-curve, but you can see a lot of that S-curve is also driven by that shortened QL. So before, when someone does come in, let's say, for example, with a scoliosis, even a younger child, it's so important to look at the QL and see whether that's the cause of that scoliosis. This is a quick and dirty way of identifying. Let's say someone comes in with a scoliosis and you identified that the right side is lower than the left side. A quick and easy way to determine whether a little bit of a lift would be beneficial in someone's shoe is simply putting a book underneath. As you can see, everything levels out, things look good. You also got to look up here. But now you can see if you put the book under the side that's longer, it makes things even worse. So it basically perpetuates that pattern of compensation. We're not going to go dive too deep into the slide, but this is just to give you an idea of how complicated scoliosis really is. Why is the scoliosis happening? Is it because of the pelvis, hemipelvis issues? Is it the limb? Is it angulation at the L5-S1? These are all different things that could be causing that scoliosis. Compensation for a tilted sacral base. Think about a house. The foundation's off. Well, the house is going to be tilting a certain way. Same thing with your body. If that sacral base is tilted a certain way, well, guess what? The spine is going to have to compensate, hence give you that scoliosis. So this is very important to kind of figure out, is this going to be potentially the solution? Or is that one QL trigger point that's shortened for whatever reason, is that causing the scoliosis? These are all the different things that you have to look at. And this word gets very complicated, and it's not as easy as a lot of people make you think it is. Corrective actions: learn to use but not to abuse weight-bearing and postural muscles, modifying and avoiding exceeding muscle tolerance and stamina. So you don't want to do things, let's say if you're bent over. As a physiotherapist, I'm bent over for multiple hours. I'm often rotated and bent, which is something that you don't want to do, which says avoid flexion and rotation for prolonged periods. That's the problem, and that's one thing that people will end up doing and causing the issues. So number one thing as a physiotherapist is identifying which activities are most likely causing these trigger point activations, trying to figure out if we can find an alternative way, and then also try and give patients some homework that's gonna manage these trigger points, such as a lacrosse ball and different things. Another thing, sleeping recommendations: avoid sagging mattresses, keeps the spine neutral, use a firm or flat mattress, as well as avoid sleeping flat on the back with knees straight, increases lumbar lordosis, increases the chance of that QL muscle being shortened, and you don't want that.